Hello to everyone. I will speak about pregnancy, lupus, and antiphospholipid syndrome. So when you take care of a patient with lupus and antiphospholipid syndrome who is pregnant, you have to assess 4 aspects. The lupus, that must be inactive, antiphospholipid syndrome, or antiphospholipid biology, and we'll see that that's the main point, anti-SSA antibody, and treatment to make sure she has everything she needs and she don't have what she doesn't need. She doesn't have. So we'll start with lupus. We have this first large prospective study, the PROMISE study that you might know, in which 385 patients with lupus were assessed prospectively during their pregnancy. You can see that a third had a past history of renal manifestations, and only 63% were treated with hydroxychloroquine. With that in mind, 4 out of 5 pregnancies were normal, with no obstetrical complication, while 1 on 5 had obstetrical complications. So for these complications, we call them adverse pregnancy outcome, with mainly preeclampsia, HELP syndrome, fetal death, and small for gestational age. It occurred mainly when the patient had lupus anticoagulant. That was the main driver of this complication, but also hypertension in non-white patients in US were a risk factor. When you don't have that, obstetrical complications occurred only in 8% of the patients. So the prognosis was good in the absence of these risk factors. Regarding flares, you can see that some flares occurred, but not so frequently, especially for the severe flares in only 2 to 3 patients per trimester. So few severe flares, if little or no activity. We now have data from France. In France, we have a group called the GR2 group, for group that focused on pregnancies and rare systemic diseases. And we assessed the first 238 women with 238 pregnancies, because we took only 1 pregnancy per patient. And we looked at the results. So most of them had living birth, knowing that they were included usually at the end of the first trimester, so we don't have the miscarriages, early miscarriages. Maternal flares were observed in around 15% of the pregnancies, usually not severe. And the main predictive factor, and even the only one, was hypocomplementemia at inclusion. Knowing that all the patients, or almost all the patients, were treated with hydroxychloroquine. Regarding obstetrical complication, the rate was 14%. And as you can see here, if we look at the risk factors for adverse pregnancy outcome, it was damage and lupus anticoagulant again, as in the PROMISE study, but damage was also an important risk factor. So that's important to know, and that's important to explain to the patients, because when you have a young lady who has lupus and who doesn't always take the treatment and who might relapse with renal flares, they may develop renal damage. And this is an important risk factor for their future pregnancies. So that's a good way to improve adherence of the patients. And you should explain that to them, that what happens at 18 years old, 20 years old is important for the obstetrical prognosis in 5-10 years. So it's a way to make them take that treatment. We did not see any impact of remission or low lupus disease activity, probably because all the patients had hydroxychloroquine and few had activity of their lupus because of that. With the GR2 study, again, we recently assessed fertility treatment impact. So we had 630 pregnancies, mainly on naturally conceived pregnancy, but 53 with assisted conception. As you can see here, regarding the flares, there were no differences in flares during pregnancy, whereas or not they had assisted conception, and same for adverse pregnancy outcome. So a good prognosis, and most of the patients with lupus can benefit from assisted conception, providing they are well treated and well controlled, but that's no more contraindicated usually. Now we'll speak about antiphospholipid syndrome and antiphospholipid biology, because that's the most important when you have these patients. You all know that we have new criteria for antiphospholipid syndrome, classification criteria. You know that you must have clinical and biology, of course. You have here everything, and here, as you can, you know that we need it's with some. It's weighted, so we have points. You need 3 points of clinical and 3 of biology at least, and you must eliminate other explanation for the clinics than antiphospholipid syndrome. So if you look here, you can see that for pregnancy, if you have only a consecutive prefetal loss or early fetal death, or if you have a fetal death without preeclampsia, without any placental insufficiency, you have only 1 point, and you don't have enough, if it's isolated, to conclude that you have antiphospholipid syndrome. So that's the main changes. So I used to speak about first trimester and then second and third trimester, but now I won't speak anymore about first trimester, because with the classification criteria, we have shown that finally that's not really antiphospholipid syndrome. And actually, if you take women who have relapses of early miscarriages, they may have antiphospholipid biology, usually only IgM that doesn't count anymore in the antiphospholipid classification, by the way. But this biology is no more frequent than in the general population. So it's not antiphospholipid syndrome. And if you take care of patients with antiphospholipid syndrome, they don't have more biology than they don't have more miscarriages than the normal population. So it's really distinct to be distinguished from antiphospholipid syndrome, and that's something else. So we'll speak about the second trimester essentially. So I've started with the take care, because that's where you may have big trouble with your patients and complications, even mortality. So take care if you have this lupus anticoagulant. That has been shown by the PROMISE study more than 10 years ago. They took only patients with antiphospholipid biology. So they didn't all have antiphospholipid syndrome. Anyway, if you take the biology, if you have no lupus anticoagulant, you have only 3% of adverse pregnancy outcome. If you have this lupus anticoagulant, it increases to 39%. You can see that it's very different. No such effect from anti-cardiolipin antibody or anti-beta-2-GP1 antibodies. So the message is very simple. If you have a lupus anticoagulant, that's the best predictor of adverse pregnancy outcome, and you must be very careful with these patients. Again, take care because all these complications, HELP syndrome, preeclampsia, that's an old study, but the importance is here on the moment you will see these complications. As you can see here, the HELP syndrome occurs during the second trimester, mainly during the second trimester. And that's important to know, because an obstetrician faced with an epigastric pain at 20 weeks might not think about HELLP syndrome, preeclampsia. So you have to know that, you have to inform your patients, and you have to be very careful if anything happens here. Also take care because these patients may face catastrophic antiphospholipid syndrome, and that's not rare. We have observed that in the prospective GR2 study in 1 to 2% of the patients. It's almost always the same thing. You have a patient, she's well treated with aspirin, low molecular weight heparin, and despite this, she develops, usually during the second trimester, an HELLP syndrome. So at the beginning. Then, because of that, you have to induce the delivery to protect the mother, and she will improve, but transiently, because then in the following days, she will develop more systemic symptoms of catastrophic antiphospholipid syndrome. In the literature, the mortality was 50% in the women. Now that we know this, that we know how to treat CAPS and to recognize CAPS, mortality in our theory at least was 0. But fetal mortality is high because when it happens very early in the pregnancy, there is nothing you can do. So the message again is clear. Take care if you have an antiphospholipid syndrome with HELLP syndrome during the pregnancy, because even after, especially after the delivery, it's not finished. You have to be very careful. If platelets decrease, or if you have anything else, you must start a treatment with steroids and IgIV, for instance, if it's not severe from the beginning, to avoid a complete CAPS. And you have to be very careful with anticoagulation, not to stop it after the delivery. So take care anyway, and this is no more in press, sorry, this has been published. More than 168 prospective pregnancies, all with antiphospholipid syndrome, half of them thrombotic and half of them with lupus anticoagulant. So first of all, they were very well treated. We are pretty proud of this in France, with almost all the patients on aspirin and low molecular weight heparin. Despite this, as you can see, 1 out of 5 developed placenta-mediated complications at any terms. And this article focused on thrombosis and severe hemorrhages. Sorry, that's still in French, never mind. 10% had one of these complications, often intricated, and thrombosis included 2 or 3 catastrophic antiphospholipid syndrome. Again, we observe no thrombosis and no severe hemorrhages if in the absence of lupus anticoagulant. So once again, this is the driver of complications. Importantly, and again, that was pretty always the same, the patients had HELLP, preeclampsia, small for gestational age. They were delivered usually early because of that, and then they had severe hemorrhage, usually in the postpartum, and anticoagulation was decreased and that thrombosis, or they first had thrombosis and then severe hemorrhage. So it depends, but all this goes together. So that was the most important in my mind. Now we'll speak about anti-SSA antibody and neonatal lupus, which has a not very good name anyway. So here because the mother don't have lupus and the baby don't have lupus. So the cutaneous manifestations look like subacute cutaneous lupus, also associated with anti-SSA antibody. So as you can see here, it's often on the face, often around the eyes, often annular lesions. As you can see here, it can be present at birth or happen in the following days or weeks sometimes. Here, a nice image from the New England Journal of Medicine. Or here, as you can see, or here, a severe manifestation, and then the girl has no more sequela because it will disappear without anything. The most complicated manifestation is the congenital heart block, as you can see here. It's usually found at 22-week gestation when women in many countries have their second ultrasound, and the ultrasound showed that the rhythm, fetal heart rhythm is very slow because the baby usually is around 130 or 40. And the dissociation is complete with a congenital heart block, usually permanent and complete from the beginning on healthy hearts. Usually there are no explanation for the congenital heart block, no big malformation, and in healthy women. So it is usually recommended to monitor the pregnancies with anti-SS antibody to see if a congenital heart block happens. And it is usually recommended to perform one ultrasound every 1 or 2 weeks between 16 and 24, 28 week gestation. This complication is rare. It occurs in 1% of mothers with anti-SS antibodies and connective tissue diseases. The congenital heart block is usually discovered around 22, 23 week gestation, a date where you will discover it anyway with the usual ultrasound. It's usually complete. And there is no specific treatment. I don't have time to develop this, but we have shown, we know with many registries, the US one and the French one especially, that there are that fluorinated steroids are of no help for that. They don't decrease pacemaker implantation, they don't decrease the type of congenital heart block, they don't decrease mortality, even late mortality. So it's no more recommended, especially because fluorinated steroids are associated with side effects on the fetuses and the mothers also. So, knowing that, if you do what is recommended, you take 100 patients, you do more than 500 ultrasounds, additional ultrasounds, you discover one congenital heart block that you would have discovered anyway, and you do nothing because there are no treatment, at least currently. So, that's a lot of ultrasounds for nothing. That's why we have written this viewpoint in the Lancet Rheumatology, detailing all this and advocating for a big reduction on ultrasound. Now we don't do this anymore in our center, at least. For the prevention of congenital heart block, we have one retrospective study and one prospective study, but without control group, that suggests that hydroxychloroquine reduce the risk of congenital heart block relapse in the recurrence in the next pregnancy. We don't have a randomized study, but since that's a good treatment, it's logical to start this treatment in these patients. We'll finish with the treatments. So it starts with the preconception counseling that allow to recognize the rare contraindications. We have very few now, mainly severe damage. To estimate the risk of lupus, antiphospholipid syndrome, anti-SS antibodies as discussed here. To assess TSH, immunizations, pertussis is usually performed during pregnancy now. To adapt the treatment, to give folic acid, to inform the patient, especially to reassure the patient on the low risk of transmission of lupus, and to start the multidisciplinary monitoring to explain the patient that she will have a multidisciplinary team taking care of her. Regarding the treatments, we have the recommendation, the 2025 recommendation of the EULAR on drugs. You can look after them, and we have recommendation for lupus and antiphospholipid syndrome. So, pregnancy and the lupus part, we need to have no flare for at least 6 to 12 months, especially if it's renal. We like to have inactive disease. Lupus equal hydroxychloroquine in my mind, very important treatment, and make sure that she takes it. So in France and in other countries, we can measure hydroxychloroquine to make sure that they take it and that we have hydroxychloroquine in the blood. Steroids are not mandatory, and we try to give the lower dose possible, usually 5 mg per day or less. Immunosuppressive agents may be necessary, usually azathioprine or tacrolimus. And aspirin is given in patients at risk of preeclampsia, mainly those with antiphospholipid antibody and those with past renal involvement. Regarding antiphospholipid syndrome, patients with thrombotic antiphospholipid syndrome are usually treated with warfarin on the long term. When they become pregnant, you don't need to change before, but at the beginning of the pregnancy, as soon as possible, they stop warfarin, and because it's teratogenic, and they start aspirin, low dose, 100 milligram in France, sometimes increased to 160, better taken in the evening for the biodisponibility. And we add a low molecular weight heparin twice a day, usually enoxaparin. For the patients with no thrombosis, so only obstetrical antiphospholipid syndrome, only, or those with strong antiphospholipid biology, even with no obstetrical events, they are usually on aspirin, 100 milligram per day. They usually add low molecular weight heparin as soon as they have a thrombotic risk in anyone. So when they are pregnant, they continue aspirin and they start their low molecular weight heparin again. The place for hydroxychloroquine and steroids is very low in this context, but in some cases it can be given. You may have seen that certolizumab pegol could be given, that the impact study performed by Jane Salmon. It was published in 2025, very recently. So in this study, there were 51 patients, all with antiphospholipid syndrome, all with lupus anticoagulant, who received certolizumab from 8 to 28 weeks, in addition to standard treatment. 45 had analyzable adverse pregnancy outcome. The other had miscarriages or malformations, so were not analyzed. Among these patients, 20% had an adverse pregnancy outcome, which is significantly lower than historical controls. They observed one maternal death due to severe hemorrhage, maybe in the context of catastrophic antiphospholipid syndrome. I don't know, that's not very clear in the article. And some neonates did not survive. The authors concluded that certolizumab appears effective in preventive placenta-mediated adverse outcome in high-risk patients with antiphospholipid syndrome. We analyzed in the GR2 the patients who had all the inclusion and exclusion criteria for the impact study. So we had 101 pregnancies. We used the same definition for adverse pregnancy outcome. And without certolizumab, but just with the standard treatment given in our patients, we had only 12% of adverse pregnancy outcome, which is, of course, no more than the 20% found in the PROMISE study, with comparable patients, especially in terms of ethnic origin, etc. So I'm not convinced that patients with adverse antiphospholipid syndrome should receive certolizumab, at least until we have more data. Finally, the management of the pregnancy is clinical first. So you need to monitor blood pressure regularly, to have proteinuria, to make sure that there are no epigastric pain, and to be careful if you have anything. The biology is also very important. Hemoglobin, platelets, creatinine, transaminase, proteinuria, of course, to see if there is lupus flare, of course, but also placental insufficiency. And now we have the ratio SFLT1 over ELGF, which is very important because it shows how the placenta works. And if it's normal, there is a strong negative predictive value. When it's lower than 38, you know that there are no preeclampsia. And that's important because in some patients with lupus, they may start the pregnancy with damage and with proteinuria, and physiologically, proteinuria will increase during the pregnancy, and you may have 2 grams or 3 grams of proteinuria, sometimes with a worsening of pre-existing blood pressure, and you don't know if you have preeclampsia. And before, these pregnancies were terminated because of concerns for the mother. But now, if your ratio stays normal, you can eliminate preeclampsia and just monitor. And if the mother is fine and the fetus growth is fine and there are no suffering for the fetus, you can continue the pregnancy with a strong management, of course, but you can continue it and not with no interruption. So that improves the prognosis, and that may explain why the impact study showed that the prognosis of the patients have improved over the year, because I think with that we reduce the diagnosis of preeclampsia in these patients, and we diagnose just damage. And finally, the monitoring includes echographic monitoring, of course, for fetal ultrasound to assess the growth, and the Doppler, which shows how the fetus is doing. Once again, that's multidisciplinary. It's important to have close discussion with the obstetricians especially, but also with the pediatricians, the anesthetists, etc. Well, that's finished. I hope everything was clear, and I remain at your disposal if necessary. Thank you.